Before introducing the speakers, I just wanted to say something about the background to the project and offer some initial reflections on the case studies that we're going to be discussing today. It's a hugely ambitious program that we're doing with Gates, and Joe is going to talk about it in a moment. But we're covering 25 different case studies in 8 different dimensions of well-being, and then synthesizing the research and the evidence and trying to bring it to bear on the debate over the post-2015 goals, and really to use the research evidence to inform the thinking of governments and donors on some of these critical health policy issues. And all of that sounds pretty straightforward if you say it quickly, but each part of it is actually really tough to do. And we've been blessed, I think, by having fantastic research partnerships. We have a great team in ODI that's been working on it and taking the program forward, and actually a great working partnership with Gates as well. It strikes me that this is a really timely moment to be having this discussion, because universal health coverage is back on the international agenda in a way that I think it would be fair to say it really hasn't been since the late 1970s and 1980s. And so there's a huge opportunity to take this issue and to turn it into something practical and meaningful that could transform the lives of an awful lot of people. The fact that universal coverage is now in the post-2015 framework, I think pretty high up on the shortlist for inclusion in the post-2015 framework, tells you something really significant. It's pretty much the only really substantive policy intervention commitment that has made it down the slalom of negotiations in the high-level panel report and come out at the other end, and is now being discussed by the open working group. So that's all very positive. I think also for me as a non-health expert, it's often helpful to stand back and just remind ourselves that what's at stake, of what does the deficit in universal health coverage actually mean for people. And one of the things that it means is that over 100 million people every year are forced into poverty because they can't afford health costs. It means that many millions more than that either delay treatment or forego treatment because they can't afford it, with sometimes fatal and regularly very damaging consequences for their lives and their livelihoods. It means that millions of people, if they do have access to health services, have access to absolutely appalling second-rate provision, where the health providers aren't trusted and where the treatment that is delivered is of exceptionally poor quality. I have to say, again, I'm speaking strictly as a non-health expert, that I partly cut my teeth in research and advocacy on health when I was in Oxfam back in the early 1990s, visiting Zambia. And it really struck, and Zambia at that time, like much of Southern Africa, was introducing user fees, user charges for healthcare. And what one discovered from that experience is that ideas really do have an impact on development. In that case, it was really bad ideas, most of them coming out of the Columbia Public Health School master's program. But these were nonetheless ideas and practices that really did transform people's lives overwhelmingly for the worst in that case. And I think it's really incumbent on us as a research community and as a practitioner community to frame this universal health coverage debate in a way that produces benign transformation rather than the sort of malign transformation that we've had in the past. So I suspect that nobody in this room would object in principle to the idea of universal health coverage. But it does, actually maybe I should ask people to remember to turn their phones off. I mean, it's nice speaking to music, but it's a little harder to concentrate. But I do think that the broad consensus and the momentum that we've got behind universal health coverage now can sometimes obscure some of the more difficult issues at stake in that agenda. And one of them is, and it's a given that if you attain universal health coverage, of course the great disparities based on wealth and gender and where people live would disappear by definition. But actually getting there, getting to the nirvana state, is a tricky business. And we know from the evidence of a lot of countries, and actually there's a brilliant report by Adam Wagstaff and colleagues in the World Bank on this, which is tracking health disparities across 64 countries using demographic and health survey data. It was published a few days ago. And it shows that in almost half of those countries, even though the country is making progress, the gaps between rich and poor are actually widening, and the disparities within the country are widening. And there's been a lot of research on this from Rockefeller, from Save the Children, from WHO, from UNICEF, pointing to that story. So I think it's really incumbent on us to think about the equity dimension of universal health coverage. And I think to undergird the whole idea with the principle of progressive universalism, that I think what we see over and over again, whether it's in health or in education or water and sanitation, ensure that the poor share in the benefits at least as much as the non-poor, and preferably more than the non-poor, is something that we somehow need to land in this post-2015 discussion, which I think isn't there at the moment. So in thinking about the progressive universalism and universal health coverage challenge, to me there are four broad sets of issues raised by these papers, but also more broadly. One is about institutions. It's one thing to adopt targets. It's another thing to reform and develop the institutions that can actually attain the targets, working from where you are to where you want to be. And this is an agenda that that spans a very wide area. That how do you recruit and train and deploy health workers? How do you recruit and retain the best public administrators in the health system? How do you govern procurement chains, delivery chains, cold storage systems, and so on for drugs? These are public administration challenges which are tough to achieve, and I think need to figure very prominently. Finance. That again, it's great that so many donors have signed up for the principle of universal health coverage. We know from, if the figures are correct, that the Chatham House paper, which updates the costs for providing minimum basic health care provision, which estimates it at around $86 per capita in government spending, not in out-of-pocket spending. And we know that even in the poorest countries, that even if they meet the 5% of GDP health spending target, there's still a huge financing gap, probably in the order of around $30 billion. So, it does seem to me that commitments to universal health coverage have to be backed by financial commitments. And if they're not, I think it calls into question the global partnership on health. Of course, there are really important domestic financing issues as well, which which have been dealt with in some depth in WHO reports. But it does seem to me that if we're serious about progressive universalism, we have to recognise that the key financial vehicles for getting there are general taxation, public finance, and compulsory and universal health insurance, with the coverage of the poor supported through general public revenues. The idea, I think, that community-based insurance is the magic ticket answer is mistaken. A third area is the role of donors and donor partnerships. That that in many countries, donors are a significant part of the financing envelope for healthcare. But as we know, that there are problems and difficulties with the aid architecture in health. It's fragmented in some cases. It's very disease specific, which has strengths and weaknesses. But also we know from these studies that there are many conditions under which donor partnerships have delivered real results on the ground, and understanding those conditions is key. The fourth area, and for me this is the most important one, is the politics. And I'm often struck, you guys are all experts in this room, so I hesitate to say this, but I'm often struck by, in a lot of the universal health coverage debates, that we focus on the technical. what drugs you need to get to who at what cost, and the cost benefit analysis and all of that sort of thing. And some of the research in the Lancet on this has been absolutely path-breaking and is fantastic. But ultimately, what really counts here is the question of how do you build the political coalitions, the alliances, the leadership commitment that can actually see this through. And we know from the success stories that the coalitions can take many different forms. It looks very different in Thailand than it did in Brazil. But there are some common elements, and I think one of them is that the reforms are designed in a way which benefit the poor initially, but offer benefits to a wider group over the longer term, which creates a constituency for supporting reform and enables the reforms to survive transitions across political cycles. You know, that's been features, I think, of some of the success stories in Mexico and Brazil. Actually, it's possible institutionally, even in the most difficult environments. The study of Mozambique, there are a couple of graphs in there that I would really encourage people to look at, which show these dramatic reductions in child mortality for the poor, for the poorest 40% in particular, and a process of convergence between the poor and the non-poor with respect to child survival, and between urban and rural areas. And actually that is a great achievement. It's not a universal story. It bucks the trend, which a lot of the other research that I've mentioned has identified. And understanding how that was possible, I think, matters a lot. The example from Nepal of a country that, despite civil war, despite slow growth, was able to very significantly reduce maternal mortality through quite a curious political coalition, actually. You know, the civil service in the health, the commitments from international support, and the critical role of civil society. And the cases of Cambodia and Sierra Leone on neglected tropical diseases. And I think, again, it's an extraordinary institutional story, actually, of, how these countries generated the political momentum, the finance, to really undertake health investments that have clearly transformed the risk profile facing a lot of the poorest people in that country. There's a whole bunch of areas which I know are going to come up in discussion, but for me really jump out from these studies, which is one, we do need to have this dialogue over how we land equity on the agenda. And if we do land it on the agenda, what would the realistic benchmarks look like? What would equity goal look like? It's easy to adopt targets for 2030 for most governments, because the governments that adopt them know they will never be held responsible for them. But how can you set nearer term targets that could actually enable us to hold governments to account? How do we generate the data to monitor progress against those targets? I'm increasingly struck by just how appalling the quality of data is on many of the basic health indicators, especially in the poorest countries. If you think of maternal mortality as an extreme example, but it's also true of infant mortality, I would argue, of stunting and other areas. So, what role can the data revolution play in addressing these problems? On the aid question, I'm really struck by, I'm a great admirer of Angus Deaton. And Angus has done a fantastic book on health inequality, but the last chapter has an incredibly pessimistic message on the role of aid and aid partnerships in transformation and expanding opportunity in developing countries. I think the argument is flat wrong and indefensible, but I think this type of research evidence demonstrates that it's wrong. And we should, I think, be stronger about using this in public debates and making the case that aid can work. It doesn't automatically work, but there are conditions under which it can work. And finally, this key question of building the political coalitions for change, of understanding where the political leadership comes from, what drives it, and so on. So that's just some initial thoughts from me. I'm now going to pass over to people who know much more about health than I do, starting with Joe Sorrell, who's Managing Director for Global Policy and Advocacy at the Gates Foundation. Joe, you're going to speak for 10 to 15 minutes, I think. And then I'm going to pass over to Fiona Samuels, who's a research fellow here in social development and health at ODI, and has been working closely on the reports and the synthesis of the reports. I'll introduce the other speakers a little bit later. But Joe, over to you.
Great.